Okay. All right. Hello, everyone. Hi. Hi. I am very, very happy to see so many faces, familiar faces, people in the community that represent a different sector of the community. I think that's very important. So hello and welcome to the Addiction Awareness Campaign launch. Thank you for those who are present and those that are attending online. We are live streaming this. This event is one piece of a larger movement to come together, raise awareness, and implement programs and activities that prevent addiction, support families and individuals, and promote recovery. Additionally, we hope to educate the community on the impact of addiction. In 2020, drug overdose deaths increased by 16.5% in Missouri. 1,842 people lost their lives in 2020. That's an average of 5 deaths per day, just in Missouri. Just up the road from us, St. Louis metro region continues to be the epicenter of overdose deaths in Missouri. If nothing changes, our proximity to St. Louis only makes us more susceptible to the same tragic outcomes. Addiction does not have to end in death. Recovery is possible. Treatment can help people get their lives back before it's too late. Addiction is a disease that for many involves long-term follow-up and repeated care to be effective and to prevent relapse. This is where community can play a role through its resources and willingness to accept and support those in recovery. The campaign aims to increase awareness that prescription and non-prescription drugs can be highly addictive, dangerous, or even fatal when not taken properly or when abused. Notably, we reinforce that help is available for those suffering from drug use disorder and encourage those struggling to take advantage of the help and resources. Our vision is to bring together state and local public officials, public health agencies, law enforcement, educational institutions, community organizations, and interested individuals to share materials and resources to support local prevention activities and raise awareness about the risk of opioids and combat addiction. As you can see, when you look around this room, we are already moving towards this vision. Pulling together community resources and invested organizations is critical to our success. An example that I would like to highlight is our biannual drug take-back events. These events enable individuals to dispose of their unwanted or expired medication safely, conveniently, and anonymously. Too often, unused prescription drugs find their way into the wrong hands. That is dangerous and often tragic. According to a study by Substance Abuse and Mental Health Services Administration, an estimated 18 million people have misused medications at least once. National Institute of Health relates that prescription drugs taken non-medically are among the drugs most commonly used by 12th graders after alcohol, marijuana, and tobacco. So it's the top of the list. Every pill properly disposed of is one less pill in the wrong hands. The most recent drug take-back event disposed of 49 pounds of unused, unwanted medication. The success of these drug take-back events was not the result of a single organization, but the collaborative effort of many. We relied upon the assistance of the St. John County Memorial Hospital Pharmacy Department to promote the event. The St. Genevieve Community Services Forum organized and staffed the event. The St. Genevieve Fire Department provided us with the location at the firehouse, and the St. Genevieve Sheriff's Office for its personnel and the role in collection and disposal. That's just one example of a successful collaboration in the fight against drug addiction. Today, our invited speakers highlight the actions that are being taken in our community. We hope that you learn and are inspired to support their actions as they continue their efforts. So our first speaker is Laura Fowler from the Pharmacy Department. She's the director, and she will talk about what the hospital has done to limit opioid prescriptions.
Okay, so I am just going to talk briefly about what our hospital is involved in to limit opioid use in our community. Before I start, I just want to clear a couple of definitions. I'm going to use the term MME, and when I use MME, I mean morphine equivalent. And that's just a term that we use that's a value assigned to opioids for us to help determine the potency or the strength of the opioid. So it helps us determine when we're prescribing it, the risk of the agent, the risk of the dose, the risk of the patient for overdose, and the risk of the patient for addiction. So that's one term. And then another one is, okay, when we talk about morphine equivalent, when a doctor writes an opiate, they add up the amount of morphine equivalents of that prescription. If that morphine equivalent totals 50 or above, it increases the risk of overdose and addiction by double. If the morphine equivalent goes up to 90, it increases the risk even more. And as we get to 120, the risk is very, very high. So we had some actions to help with that, which I'll talk about in a minute. So the other term I'll be using is PDMP. So that is a prescription drug monitoring program. It's a real-time electronic database that we use as providers in the doctor's office and the pharmacy. It helps us detect risky behavior on the patient because we can see if they're using multiple doctors or multiple pharmacies, or if they're paying cash for prescriptions. And it helps our physicians improve prescribing because if they check the PDMP, it calculates the morphine equivalents for them of all the prescriptions that the patient's on. So it's a very quick way to do that. And also the providers get a report card back quarterly that compares them to other providers so that they can compare themselves if they're writing more or less to see if they're a problem or not. And it's exciting to say that we just moved from using the St. Louis County PDMP that our state just approved to have a statewide PDMP, which is really exciting. We were the only state that did not have that. So it's exciting to know that. So where did our hospital begin? In 2016, the CDC released guidelines for pain management, for chronic pain management. It was 12 recommendations that were given to the doctor to help them prescribe more safely. So our hospital reviewed those, and we picked a few that we knew we could target and take action on. So we wanted to limit those MMEs and the high MME prescriptions. We wanted to limit the day's supply for acute pain prescriptions. The CDC recommended 3 days or less. We wanted to not combine opioid prescriptions with benzodiazepine prescriptions like Xanax or lorazepam, because that, the CDC said, was a very risky prescribing pattern. We wanted to offer Narcan to anyone on high morphine equivalent prescriptions. And we wanted to begin tapering our high morphine equivalent patients down to more safe doses if that was possible. So in 2016, because of those guidelines, we created what first was known as the Narcan Committee to help distribute Narcan in the community, but quickly that committee became the Opioid Stewardship Committee because we found there was much more we could do than just Narcan. So real quick, what our committee, our initial items that we did, we had to get administrative support, which we had those recommendations and data that we could use to gain administration support so that our doctors would then have the drive that they need to make changes in their prescribing habits. We updated our controlled substance policies right away. We knew we needed to do more drug screening. We needed to make sure our pain contracts were being used and that our patients were having routine visits, especially if we were tapering their dose down. We did initial audits on those action items, and any provider that was an outlier, we had a one-on-one with them and described their prescribing habits. And a lot of them were like, you know, that's me. Like, I don't know that they realized they were refilling those prescriptions one after the other. So that was very beneficial. We added when the doctor wrote an opioid prescription that he got a pop-up to write Narcan with it. So it helped encourage the prescribing of Narcan along with those prescriptions. We added a pop-up to each opioid prescription that told the physician how much morphine equivalence was in that tablet so that he could quickly, as he was writing, it gave him a thought process to say, hey, I need to think about how much morphine equivalent I'm writing here as I'm doing it. because it helped us limit the amount they were given and it decreased our prescribing substantially. We got a physician who became certified to do medication-assisted treatment, and he's our Suboxone provider. So our physicians had some problem patients that were either using illicit drugs in combination with their opiates, or they were on very high doses, and they really didn't know what to do with those patients. So offering a Suboxone doctor was kind of an avenue to give them a resource to do with those patients. We also added a recovery program, and I guess you'll be speaking today as well. In the hospital, it's called New Vision, and we just help patients with the first 3 days of the withdrawal process and get them through that. And then we established also a pain management physician, because patients on those higher morphine prescriptions are at increased risk for overdose and addiction. So we encouraged our primary providers, if they were on 90 morphine equivalents or more, to transition them to pain management just to get that in-depth care. And then we increased our patient education. We made a specific opiate handout that we gave to patients on the risks and on how to dispose of opiates. And then we encouraged our physicians, we made sure they all had access to PDMP and that they were using it. So that's kind of our biggest actions in our committee. I just have a couple more slides. So that was our initial items of the committee. And then over the years since 2016, we've also held our drug take back events. We do community education like this, or we did a hidden in plain view. We work with health department to bring speakers into the community, into the schools. We invited a DEA speaker to come talk to our physicians on the risks of prescribing opiates and the importance of good documentation because of the liability associated with it. We require our physicians to do annual opioid education now. And also we just recently, if we have a positive drug screen for pregnancy, they involve our social worker and do a consult with her, which was pretty exciting. So just some results that from our initial audits that I talked about. This is in our emergency room, and we first started our first audits in 2017. We were riding over 50% outside of that CDC recommended range of 3 days or less. So over half of our prescriptions weren't following those guidelines. So after our one-on-ones, we got down to almost at 5%, which was awesome. But then we had some turnover in the emergency department and some new doctors. So our numbers went back up a little bit, but we just did some more one-on-ones and they're going back down. So that was exciting to see that we were making progress. And we did kind of the same thing in our same-day surgery. About a third of our prescriptions were outside of the range. And once we started talking about opiates and their risks and the CDC recommendations, our most recent was only around 3%, which our goal is 0%, but we're pretty close. And the little peaks, I have one doctor that he likes to make sure I'm still watching, so he goes out every now and again. And then the last one, our clinics, this is what I'm most proud of because this is the risky prescribing. These were high morphine prescriptions or high morphine content, and this is mainly were our primaries. But these were 50 to 89 morphine equivalents and then greater than 90. And we did have some patients that were on 180 or better. And we've gotten all of that down to almost 0% because of our education and then sending the patients to pain management and getting that proper level of care. So almost a third of our prescriptions were being written for high morphine prescriptions, and through our education, we've managed to get those down through safe tapering. And I think that's it. No, one more. Okay. So then we also just want our physicians to not prescribe the benzodiazepines and opiates together if possible, but we also don't want them to just stop the medicines because that's not safe either. You can't just stop these meds. You have to taper them off. It's not ethical to just stop. But in April, there where you see that dip, we did some education on the risks, some in-depth risks on the black box warnings and things associated. And then our physicians finally, you saw that dip down a little bit. So hopefully we can keep that down. And that's all I have. Any questions for me?
Thank you, Laura. Thank you. It really is an effective way of prevention, keeping it out of people's hands. I just think that's wonderful. Danny will be up next. She is from the St. John County Health Department. She is a nurse and she has been tasked
Like she
with
said, I'm Danny. I'm one of the
managing
nurses at the health
their
department.
Narcan.
I'm just going to give you a brief rundown. I don't have a big PowerPoint or anything. Just a rundown of what our role is in this awareness campaign. I just recently took over the Narcan distribution for the health department. And I will preface this by saying I personally have never been affected by opioid addiction or overdose. But when I was asked if I wanted to take over this part of the program, the first thing that comes to mind is my own kids. They're 1 and 4 years old. They haven't had an opioid in their body at this point in time. And like any other parent, I wouldn't want that for them. I wouldn't want them to be affected by this, but things happen. So I would hope that anyone in the community would think of their kids as well when they're advocating for what we need here. So at the health department, we do Narcan distribution for free. This isn't a new program. We've been doing this prior to me starting there. We give out the Narcan in the form of a nasal spray, and I did break some of our practice applicators in case no one's ever worked with Narcan, just to see what we're doing. So this given Narcan can obviously work on the receptors that the opioids bind to reverse the effects such as the decrease in respiratory drive that eventually leads to the mortality in our overdose cases. So if someone was to call the health department at any point in time and want Narcan, the biggest thing I want the community to know is we do not question. We're not going to say, who is this for? Why do you need it? What's going on? We don't care. You think you need Narcan? We're going to give you Narcan. Whether it's because you have a family member, a friend you know is using and you want to have this in case you need it for them. Maybe you have a teenager coming home from a knee surgery with opioids and you just want to have it in your house just in case. That's fine. We'll give it to you. So whatever the reason, we won't question. We do hand out a bag that contains 2 of the Narcan nasal sprays in it. We also include in the bags a one-way airway. So if you should need to give CPR to the victim and you're worried about whatever drugs they used, what's on their face, this could provide you some protection so you're not thinking about that. And we also have some information in the bags that just talk about what to watch out for in an overdose, kind of walks through the steps of using Narcan, what you should do after you use Narcan, and then some resources which we are working to update a little bit of what to do now for the person. What resources do we have in our community? So this is the program that's been in place. Like I said, this isn't anything new. What we did just recently do was add an after hours line. So we have a community volunteer who has graciously offered Monday through Friday, 4 to 6 p.m. and weekends as available, to meet individuals in the community at a specified location to deliver the same Narcan bag that we have. They don't have to say who they are. They will also not be asked, why do you need this? They'll bring the bag to them so they have it. And we do feel like this is important. We're only at the health department till 4 o'clock. If you're needing Narcan at 5 o'clock, you have someone being discharged from the hospital. Maybe they just got out of the detox program. That's when they're at very high risk for overdose. We want them to have Narcan that day. We don't want anyone waiting. So that after hours line is available now. I did find a little bit in some research I did starting with this program that a lot of pharmacies only keep 1 dose of Narcan on hand or 2 doses of Narcan on hand. Well, if that's the pharmacy that person always uses, they go there and it's not available. We don't want that person going home without it. So they can call us if it's during our hours. They can call our after hours volunteer. We can help them out. Questions for me? I did bring some flyers to anyone who
Next up, we do have Melissa Parsons with New Vision.
Hi, like you said, I'm Melissa with New Vision. That's a service that's partnered with St. Genevieve Hospital. It's a medical stabilization and withdrawal management program. Basically, what we see that happens a lot of times when someone is wanting to get clean is they want to get clean, but the withdrawal symptoms that they experience when they try to stop, they just can't. They're so sick that they really just cannot stop. And it's, as a couple of others have mentioned, it's really dangerous if they've been taking, opiates or benzos like Xanax or Valium to just abruptly quit. They can experience seizures. So, what New Vision is designed to do is they can, we do an assessment a short assessment over the phone as we talk with someone to see if, they're a good candidate for, the service that we offer. And then whenever, they come in, then we go through a whole history with them. Then whenever they're admitted onto the floor, they're seen by, a physician. They have a complete workup by nursing. Also, a lot of times when people have been using substances for a long time, they have a lot of underlying health conditions just from that use. So while they're there, we do a complete workup of labs, to see what other, underlying health issues they may have. And while they're there, we're talking about what kind of aftercare plan can we set them up with for them to be successful in their recovery? Because, detox is just that's the first step. We're getting the body well so that they can focus on a recovery afterwards. So for some patients, they may do a residential treatment and we have them, we partner so that when they discharge from New Vision, then they can go straight into this residential treatment if that's what they've decided is best for them. Or, we partner with, like community counseling center, for them to provide services or just whatever resources that the patient feels like they could actively participate to stay sober, because, every person's plan is going to be different. And that's why, New Vision is individualized for each person, based upon their needs. And New Vision, since we are partnered with St. Genevieve Hospital, we're able to accept most insurance plans, from Medicaid, Medicare. And that seems to be a vulnerable population right now, especially with COVID. So we're able to, provide services for those patients. Do you have any questions at this point?
You don't take insured, or is there programs in place for uninsured?
We do not have any funding for the uninsured, but we do have a financial assistance program at St. Genevieve that people can apply for. I do know that they still have to pay half of, if they're uninsured, they have to pay half of the cash price, at the time of admission. And that is something that I've been trying to work on, is to find some funding for, for this service, because, there's just a huge need. We're seeing, it's just really busy. I mean, which I'm glad we have the service, but, it's just to show that the need is still really there.
We need to get together, work together.
Yes, I would love that. If somebody calls me though, if you have someone you're concerned about and they don't have insurance, call me anyway, because I will work I work with everyone who calls. I don't just tell someone, I'm sorry, you don't have insurance, I can't help you. I work to find them resources that they can actually utilize, because I don't want anyone to feel like they don't have any choices. So
Have some cards with you?
I do, I have cards and pamphlets, and I would be happy to give those out to everyone. Any other questions? Thank you.
Okay. I'm Jennifer Hornberger. I'm with Community Counseling Center. I'm the site manager. And of course, I'm here to talk about treatment options that we have. We have MAT, which is medication assisted treatment. We are not a methadone clinic. We don't do methadone, but we do have medication assisted treatment, and that is active. We are contracted out of St. Louis with a company called ARCA. So all the physicians do telemed. So the person comes in, talks to the physician through telemed, and gets their prescription. We are monitoring all of those people through urine analysis. So just to make sure they're not using while they're getting their medications. We also have an ITCD program, which is integrated treatment for co-occurring disorders. So if they have a mental illness and they have an addiction, then they can get into that program, and it treats both simultaneously. When they're in that program, they're in a partner program for case management. So they get a case manager who's going to work with them a couple of days a week, just on basic life skills, coping skills, things like that, and to put them in touch with other resources if needed. We have regular therapy. I'm trained in addiction therapy, so they can come see me. And we, of course, have our doctors. And again, that's telemed, but they come in, they can talk to the doctors, they can get prescriptions, and they can work through us for that. We also have peer support. Peer support are people who have had addiction issues in the past or had alcohol issues in the past, and they work with them from the point of view of, hey, I've been there, I can help you, let's look for a way out of this together. So they're also available. Any questions?
Back to the insurance part.
Okay, yeah. Yeah, case management, ITCD, and the MAT program are all Medicaid right now. We are looking into getting further funding. We're looking at getting CCBHC, which is Certified Community Behavioral Health Clinic approval, which will give us different funding, and we should be able to help people then on a variety of insurances and uninsured. Now, if they come in just to see me for therapy, we have a sliding scale, and we also have a POS fund, which helps, and they can come get 6 to 9 sessions, and they don't have to pay for that. Any other questions?
Last set of agenda, and I'll help you get set up with your PowerPoint.
Linda Fitzgerald, and I've been working with the, for the last 3 years with the Mo Works Together opioid grant, where we have taken dislocated workers who are in recovery and trained them to be peer support specialists. And
Just give it 1 minute.
my key focus as I've been working on the grant has been working with employers, trying to develop recovery-friendly workplaces. And you see up here on the screen the different adjectives of a recovery-friendly workplace. And we all would like to work in a workplace where It was supportive and collaborative and encouraging, and where people were accepting of us, and we had trust. And so the question is, why do we need a recovery-friendly workplace? And just quoting my friend Doug Swanson, an event took place back in January 1st of 2010. And that was when the oldest baby boomers, a group of which I belong, began retiring, and the effect that had on the workplace. Currently, 10,000 people are leaving the workplace, not monthly, but every day, as far as retiring. And so we anticipate in December of 31st of 2029, we will have lost 79 million workers from the workplace, and an estimated 26%, or 1 out of every 4. And this is the first time in the United States that we have not had a surplus of workers since World War II. And so where do we look? If we take just a demographic, just pulling a piece out of, and look at men 25 to 54, we find that 11% of that group are not in the workplace. They're either unemployed or not even seeking work. That's 7 million people that we could reach out to. To bring a link back to the opioid crisis, a 2016 survey, which is when 2016 is when your hospitals started to be very proactive in looking at this issue. Of that age group that were not working, 47% reported that they had taken pain medication prior to the survey. There's a strong link between work-related injuries, injuries in general, and opioid addiction. And so if we talk about the opioid crisis, or even just substance use disorder, that's alcohol, anything else that we can find to ease our pain, that usage has increased because of the COVID pandemic and the isolation that people have been in. And I found this graphic. Alan Kruger has written a paper where have all the workers gone? And this starts in 1948. I can do the math because that was the year I was born, 73 years ago. You can see our worker participation and how it went up, and now it's going down. And so where have all those workers gone? Some of them have left the workforce for reasons that Mr. Kruger speaks of, talking about the role of mental, physical, and emotional health challenges. And he says that's especially in that prime age group, both men and women between the ages of 25 and 54. And he says that is where we could look for workers. but how? If we look at this group that exhibits the lowest level of emotional well-being and life evaluation, and isn't that what starts the downhill slide as we look at ourselves? There are potentially large gains to be made by identifying and implementing successful intervention to help the prime age group, the national labor force of men and women, to lead more productive and fulfilling lives. And so we find that substance use disorder is embedded in every industry. The three key industries that see the most overdose deaths and are healthcare, transportation and warehousing, and construction. But we find it in every community, rural, metropolitan, and we all know someone. And so it's very important to have strategies to heal broken lives and to reclaim superior workers. And they are superior workers often because they're our most valuable people, and they push and push and have work-related injuries and take the pain medication and show up every day. We have to reclaim them. We can't throw them away. And so the search for the recovery-friendly workplace asks, what can an employer do today? You can know your team, build relationships, practice relapse prevention with a strong support system when someone is in recovery and they come back, view that relapse as a setback, not a failure. The EAPs that companies have are important, employee assistance programs, but they don't do enough. We need to expand insurance, and Bill, that's your question every time. We need to expand our company's insurance to support the MAT, or medicine assisted treatment, as well as recovery houses, treat opioid addiction as a chronic disease, just like we treat our diabetes, not as a lifestyle choice. That's what we look at people and go, well, they made bad choices. They didn't make bad choices. Think of it as a chronic disease. An expansion of social acceptance. Take the path of destigmatization, such as we've adopted for diabetes, cancer, all the other chronic diseases that we deal with. Support groups are invaluable, but they don't do it all. What we need with people facing re-entry into the workplace issues, oftentimes they've lost their transportation, they've lost their family, they've lost their job, they've lost so much. We need to be able to realize these things and step up. Relapse prevention is certainly important, but we're talking about a safety net, a hand up, not a handout. I believe it comes from developing these key areas. Health, learning to overcome and manage more successfully to live with the symptoms. think of it as a chronic disease, then we need to be living with the symptoms in a positive way. And that happens for all of us, whether we have an addiction or not. Home, a stable place to live, stable and safe. Purpose, we all need a purpose. Meaningful daily activities, and certainly a job, volunteer work, creative endeavors. Meaningful encouragement in society. And then we need community, relationships, social networks that provide support, not tear down, friendships, love, and most of all, hope. Recovery, and I understand as a definition, recovery is connecting to, and perhaps for the first time, purpose, foundation of belief, self-image, but most importantly, self-directed living. When we have an addiction, the addiction is driving our life. A key element to that safety net can be the workplace. We can provide all these things. Consider, if you're an employer, consider utilizing a mentor employee or to provide peer support. And I think that's key. The investment is small, the rewards are great, the training is minimal, and the benefits are immediate. So little cost with such a great return on investment. If you have a mentor employee, if you've selected someone to provide peer support to others in your recovery-friendly workplace, consider providing a transportation bonus so that your mentor employee can pick up the individual that has just come into your workplace after recovery and doesn't have transportation yet. Or a mentoring differential, like a shift differential, but it's for the hours that they're working, helping and support. Or even a special shirt or jacket that causes them to stand out, or an on-call phone or pager. A recovery-friendly workplace doesn't go it alone. It involves the whole community, and all these resources that we've heard about today have to be available. Thank you very much.
So hi, my name is Bill Kramer. And some of you know me, some of you don't know me. To be fair, I need to start back a ways and then work my way to where we're at today. So when I first got started in opioid prevention and policies and what to look for and what to watch for, the initiative was sent down from our general president, Terry O'Sullivan from Washington, I believe in 2015, Rob, wasn't it in that area somewhere? Rob's with Laborers 110 in St. Louis, and I'll mention them here in a minute. But Terry O'Sullivan was seeing a trend in 2015, 2016 that the labor force was being affected drastically by people that were getting addicted to opiates. They were losing their jobs because of opiates. They were losing their lives because of opiates. So he sounded a general alarm to all the districts. And then the districts, they put on programs, and me being a union miner with the laborers organization, I went to these programs. And I guess it was in 2016 is when I really started getting involved. And I think at that time, I think the number was 63,000 Americans died because of overdose. And what that relates to is the one thing that I remember them talking about is if a commercial airplane fell from the sky every day, 365 days a year, that would be about the total of people that were dying, would be what's dying in the United States. That stuck with me. Well, in 2017, I was going to a program that Don Willey, who is the business manager of Laborers 110, he was introducing ARCA, which Jennifer talked about using. And I thought Don was going to present, just MC the event, similar to what Australia is doing today. And I had met Percy Menzies, who is one of the founders of ARCA. And we talked for a little while, and I told him, I said, I've got a daughter that's being prescribed, heavy doses of opiates. And I was worried about her, but she was being watched by a doctor. It was all under a doctor's watchful eye. And I really didn't think anything too drastic about it at the time. So I went up to this event that Don was emceeing, and Don got up in front of the crowd, and I never will, this is my aha moment. Don got up in front of the crowd. Once everyone got seated and got quiet, he said, "My name's Don Willey. My son died of a heroin overdose. He was an addict." And he went on to tell about how his son got onto heroin, what his likes were, what he didn't like, and what a great person he was. And they didn't get to him in time. They had him on a ventilator. Don and his family got to go visit him and say goodbye before they ended life support. So Don's son lost his life, but I thought it was really courageous of Don to get up in front of this crowd of people he didn't know and say, "My name's Don Willey, and my son died of an overdose." And I thought, if anything ever happens in my life, that major, I want to be that guy. I want to be that guy. I want to be that spokesman, because no one knows. If we don't put a face with overdoses, no one knows. 63,000 people, it doesn't have a face. I get that, unless it's your neighbor, or your son, or your wife, or somebody. So as time went on, 2017 rolled around, and I continued to go to programs and learn about what I was doing. And my daughter was taking extremely high doses of opiates under care of a doctor until she had a bad urine test, and he cut her off. Said, "Find a different doctor. I'm not treating you anymore. Goodbye." So she turned to the street. She found a pharmacist up in St. Louis on one of the state streets up there that would mix her whatever she could pay for. She was, and I didn't know this until later. She started off with pills. The pills were so expensive, she turned to heroin because she was addicted. That while she was going to the doctor, prescribed her enough that she was addicted. Places, now we can't do that, thanks to some programs that are going on right now in St. Gen. So that we've got a handle on. No doctor should, and you even said it, no doctor will kick anybody out that's on a high med they shouldn't, and I don't think they would. The doses she was taking, they should have prescribed Narcan. Narcan was not available in St. Genevieve. So little did my daughter know that I had a tracker on her car. I could follow her wherever I wanted to, because at that time I was starting to get worried that she was abusing drugs. But every time I would confront her, "It's okay, Dad. I know, I've got this under control. I'm not taking anything any more than what the doctor was giving me. I got this under control." People who are using will tell you anything. They're extremely great liars, because that's what they do to either have it. They've got to. I found that out later on. So I told my wife I had to make a trip to Washington, D.C. And when I got back, I told my wife, I said, when I get back, I said, we are going to get her arrested one way or another. We've tried treatment. It failed. She'd been in and out of different treatment centers. It failed. She actually ran away from one. I think she beat me. I think she passed me going, when I was down at Cape, I think she passed me actually when I was coming home, but she was on her way to St. Louis. It's frustrating. I could spend an hour up here telling you how bad things actually got in my house. But I don't, I'm not going to take up everyone's time like that. But I wanted to tell you the story of addiction. I mean, that's what we're all doing here. And I appreciate every one of you that's here. I appreciate everyone that's live streaming. And what I want to talk about next, probably a lot of people don't want to hear. Our law enforcement community has seen it. It's an open wound. You've seen what happens when someone overdoses. There's no one there. People that have Narcan at home, they don't have it for themselves generally. They have it for their loved ones because they think someone else is in their house has got a problem. If you think you've got someone at home that has a problem, you need to sit down and talk to them, have that conversation. They're going to get mad at you. They're going to deny it. They're going to tell you you're nuts, you're crazy. I'm not using drugs. Have that conversation. It is vital you have a conversation. If you think they're abusing narcotics, get Narcan. Either get it from the health department, go to the pharmacy and get Narcan in your house. You can't save that life without Narcan. I know this. So the day that I got back from DC, let me back up just a minute. I want to just bring it back for Don's sake. My name's Bill Kramer. My daughter died of a heroin overdose. She was also saved by Narcan. And I think that's important that's what we're all doing here. That's what we're all talking about. So when I got back from DC, was in the parking lot at the airport. My wife called and she said, "Hey, Sarah got caught. She had some needles with her." It's like, oh God, she's turned to heroin. Which I had absolutely no idea. So they gave her a choice of either going to jail or going to detox. And detox is up in Jefferson County. So she went to detox, gave me 3 days to find Narcan. Well, by the time I got home, the pharmacies were closed. The next day I went to the pharmacy and I asked for Narcan. I need a box of Narcan. Sorry, we don't have Narcan. Nobody's ever asked for it. The pharmacy doesn't have it. They said, well, we can get it, but we don't have it now. I said, well, when can you get it? Well, we might get it tomorrow. I said, get it tomorrow and I'll take some. So tomorrow rolled around, they had it, but they couldn't sell it. Why couldn't they sell it? Because they didn't have the protocol yet to sell it. In other words, their main office didn't tell them how to distribute it. They didn't know if it needed a doctor's order. They weren't sure if they could take cash or insurance. So they couldn't sell it. So there's another day burn. The next day she got out. I found Narcan. It was all the way up in North St. Louis. At that time, it was NCADA, which is now Prevent Ed. But I couldn't get up there before she got out of detox. So leading up to all this, whenever my daughter would come home, especially when I could see where she had been at, I'd always, when she'd come home, I would give her 2 minutes. I would go down and I would talk to her generally through her bedroom door, make sure she was okay. I assumed she was using. So on that day, she got out of detox, checked my phone straight up to St. Louis because they detoxed her. She didn't have any opiates in her system, but she had not been treated. She still had that desire. So with no drugs in her system, she really didn't know how much to take to feel normal again. So she bought a lethal dose of fentanyl laced heroin, came home, used it. And I went down within about a minute and a half and the door in the bathroom was locked. Couldn't raise her. Got the door open finally. And she had overdosed, but when she fell in a position that rolled her head up underneath her chest to where actually everything was choked off. Her airway was choked off. Her throat was completely closed. By the time I drug her out of the bathroom, if you can imagine holding a string around your finger for 2 minutes, your finger's going to turn purple. Oh, my daughter was purple. Her face was purple. Her eyes were open. Little tiny pinpoint pupils. They were non-reactive, no breaths, no heartbeat. She was going. But something I learned at work is if you find yourself in a position where somebody is down and you're by yourself, you've got to get help. You can't save somebody if nobody's coming to help. So once I drug her out and made the assessment that she had in fact overdosed, and she was going, but she was only going by about 2 minutes. I thought there was probably going to be some chance that through CPR, ambulance getting there with Narcan, we could get her back. So I went up and I got my wife, put the dogs out. I said, call 911. I need you downstairs. Put my grandson in a chair. I said, whoever comes to the door, send him downstairs. So my wife and I went downstairs and started CPR. By that time, her color had changed. Now she was kind of elephant gray. She had blue lips, blue fingers, pinpoint pupils, non-reactive, classic overdose. I mean, these are the things that you look for. There's a lot of things that you can look for before someone's gone, but if you see that, you need Narcan and you need it now. You don't need it a half hour from now. You need to have it on hand. So I said, if you suspect anyone's using or abusing, get your Narcan and have it. You can't wait. So by the time we started CPR, now we're talking 3.5 minutes, probably somewhere in that area. And as the police officers from town, the sheriff's department, the fire department, dog catcher, I don't know who all was coming by my house, but my house was absolutely filled with people. And I heard someone finally say, don't let anyone else in, there's no room in here. And I was breathing for her. My wife was doing the CPR or the chest compressions. And every time I'd see a new pair of shoes, I could only see from the knees down. Every time I'd see a new pair of shoes walk in, I'd say, do you have Narcan? No. Do you have Narcan? No. You know, and quite honestly, I was kind of giving up hope because my house was filling up with people. And then I heard the call, don't let anyone else in. I wasn't sure where this was gonna go. Finally, the ambulance showed up. They were there in about 12 minutes, which was great. I mean, they were concerned about the length of time it took them, but once we broke it all down, they got there quickly. It took them 2 minutes just to get through the traffic and get into my house and get down to my daughter. And they started an IV. They pulled me away from her and they started to use an ambu bag to pump air into her. Started an IV with Narcan. And within just about 2 minutes, she blinked her eyes. She took a breath. She vomited because I was belly breathing for her. You know, I missed a few times. I didn't have her positioned just right. So I was actually breathing into her stomach. And when she regained consciousness, all that air came out. Everything else did too. Bottom line is we saved her life. She went into St. John Hospital where she detoxed for 24 hours, I think. She had to be stable for 24 hours before we could send her to Jefferson County. From Jefferson County, she went on to a rehab facility, and as the good Lord would have it, I got her back today. So she's been clean for almost 4 years now. It can happen, but you can't do it without Narcan. I mean, and I'll give the police, I try to get our police department, Eric, you know, I've talked to you a bunch of times about carrying Narcan. I'm gonna let you off the hook. Now Narcan is available. I think every house, personally, my thought is every household should have Narcan. It's cheap enough. If you got a fire extinguisher to save your stuff in your house, you should have Narcan to at least save a life. Tape it onto your fire extinguisher, have it available. You don't have time to wait. You can't wait for somebody else. You can carry it with you. I carry a carry it in my pocket. I mean, it's that easy, you know, it's a no-brainer and it saves lives. The law enforcement community, they can't be ready for every type of emergency. Like I said, now Narcan is available. Now everyone should have it. I wouldn't even wait. I'd say if you've ever had an opiate in your house, I would get Narcan, because the first time your grandbaby comes over and they put them on the floor, if you've ever dropped a pill, that baby will find it within about 17 seconds behind the leg of something that you couldn't find. That's all it would take is a pill for a little baby to find. And people aren't at their best when they're sick or they're hurt. They'll take their pill. They might drop one. They'll take one to fall asleep, forget about it. Baby rolls around, bam, you got an overdose. It's just a number. You know, if a baby finds a pill and overdoses, it's just a number. It'll just be another notch on an overdose. It doesn't say an accidental overdose. So when we talk about overdoses, last year there was 93,000 children that died of overdoses. 93,000. I mean, it was 63,000 just a few years ago. Last year it was 93,000. So we're going in the wrong direction as far as overdoses. We're not doing, I guess, an adequate job of educating people and getting Narcan in the right hands. And I use the word children intentionally because they are children. I mean, they were born to somebody, you know, they're somebody's child, they're somebody's husband, their wife, their daughter, their son, you know, and it impacts everybody. Once the wage earner leaves the house or the mother leaves the house, whole dynamic of the family changes. So that's what this is about. That's why I want to pull the community together and get ideas. If anyone has an idea, coming from the sheriff's department, coming from our state representative, Dale's called me up to Jefferson City before. I testified in his committee, and I'll do it again. Call me, I'll be there. Just give me enough travel time to get there, and I'll be there. That goes for Lane or any legislators in Jefferson City. If I'm needed up there, call me. I'll be up there in a flash. So we came up with an idea of a symbol. This is the purple ribbon has always been kind of a symbol for overdose awareness. So we were going to have this symbol and move it around St. Genevieve. If anyone wants this at their home, at their office, if they want me to bring it by, they can either just take a picture and I'll take it back. If they want to display it in their business, they can have it in their business. And I'm going to encourage people to sign it, because I want people, when they pass by it, I want people to know that there are people out there who care for the person like my daughter who doesn't know that this many people care. Well, there's more than this many people. There's a lot of people out there that care, but they don't feel it. They don't see it, because there's not any, they can't see it. So when I was putting this together and painting it, she said, I was telling her about people signing it. She said, can I sign it? I said, yeah, I can sign it. You know, you've certainly earned it. So I'm going to ask her to come up and sign this time, or this afternoon. I guess it's still this afternoon. So I get a pen, and this is my daughter, Sarah, everybody. She is 2 years clean. She's not going to go back. She got her addictive personality from me, and she also got her tenacity from me. So I don't see her ever going back on it. She might, I doubt it, because I'm a real stickler about things like that. I've had some problems in my past. You know, I'll admit it. I drank when I was younger. I haven't had a drink for 40 years. Smoked when I was younger. Gave them up for whatever 20-something years. I've got that addictive personality. I know if I take another drink, I'll start drinking again. I know if I take another smoke, I'll smoke again. I ain't gonna do it. I know me. So, and she knows her. So you have the honor. I'll let you sign it first. And
thank you.
Yeah, wherever you think it's. There it is. Perfect. All right, that's it. I don't have anything else, guys. Does anyone have any questions for me? I cover everything? All right. Straight?
Just any questions from anyone, comments? Any feedback is appreciated. If you maybe don't want to say anything here and you want to just reach out to me at the extension office, do call me. I am open to any type of idea that you have. You know, we have the community services forum that we meet monthly, where we could take those ideas and really implement them and put them out in the community. So it doesn't end here. Please call me with any ideas, small or big, whatever pops in your mind. I am open and I'm willing to listen. That's it. Thank you.
Thank you all.